So I'm really pleased to introduce you to our webinar on emergency cavernoma surgery. Because we're talking about surgery, there will be some images of surgery. Before those are shown on screen, Professor Andrew Brodbelt will let you know. So if you want to look away from the screen, you will have an opportunity to do so. So without further ado, I'm going to begin by introducing Professor Andrew Brodbelt. So Professor Brodbelt has been a consultant neurosurgeon and lead for neurosurgical oncology at the Wharton Centre in Liverpool since 2005. He's held various roles in local, regional and national programmes, leading care, and is an honorary clinical senior lecturer at the University of Liverpool. So in short, he knows what he's talking about. So thank you very much for joining us today. And Toni, Toni Ashworth was 40 years old when she was rushed to the Wharton Centre, where Professor Brodbelt is based, from another hospital after a third bleed and her cavernoma had grown in size. And she was operated on. And at the point she was operated on, there was a television crew in the hospital, and they were filming for a Channel 5 programme called Trauma Room 1. Since then, Toni's gone on to make a really good recovery, and we're thrilled, Toni, to have you join us so you can give that patient perspective as well as the perspective of the clinician. So thank you so much for joining us tonight.
Hi, everyone.
Hi. Wonderful. So without further ado, I'm going to hand over to Professor Brodbelt. And a hello from Spain in the chat. Hi, Spain. We've got people from all over Europe. How wonderful. So I'm just going to put the spotlight on you, Professor Brodbelt, for your presentation before we then hand over to Toni. So let me do that now. So it's over to you.
I'll just share my screen. Right, hopefully you can see the start of the talk.
We can indeed. I'll hand over to you now.
Thank you very much for that introduction, Helen. I'm not nearly as good as you make it sound like I am, but it's very nice to hear. So I'm a neurosurgeon. I work in Liverpool at the Wharton Centre, which is a big neurosurgical unit in the UK. We're a purpose-built, dedicated neuroscience hospital. We only do neuroscience there with neurologists and neurosurgeons, and we have a very large throughput. We cover a population of about 3.5 million, looking after all their neurosurgical and neurology needs. So what I'm going to do today is we're going to talk a little bit about Toni, about what symptoms she presented with. We're going to look through the scans. I've got some clips from the programme, which I'm very grateful for Channel 5 letting me use, but I'll warn you when we're going to have some intraoperative pictures. They're not dreadful, but I used to have my children, I was mentioning before, I used to have my children give me an idea if they were too extreme when I speak to patients, but I've shown them so many times and they're now all grown up that they're not very helpful in that regard anymore. So I'll let you know, and you can switch off if you don't want to see. So let's go on to the next. So I first met Toni. This was back at the end of 2022, the beginning of 2023, and she'd had a fall and they'd found something on the scan. And they were a bit worried. Everyone was a bit worried. And this was the scan. Now, these are CT scans. And if I point to things, Helen, you'll have to tell me. If I point to things, can you see them on the scan? Can you see my pointer on the scan or not really?
Can you do that again, Professor Brodbelt? Yes, we can.
Okay, so what we saw is these are scans. This is a scan as if we cut the top of her head off. This is a scan as if we cut her face off, and this scan is as if we cut her down the side. And what we can see is a black thing, a round black thing, and that's just a hole. It's filled with something that looks almost like CSF. So CSF is the fluid in your brain. You can see there's a ventricle with CSF in. It's not quite the same color, but it looks similar. There's no really underlying structure there. It doesn't really tell us what's going on. And so there's just some arrows to point to it. So it wasn't very big, 1.5 centimeters, something like that. So don't go racing into these things. She didn't have any symptoms from this that we could really pick out. So we watched for a bit. And then a couple of months later, we'd done an MR scan, which looks at a bit more detail. Again, same sort of images. So this is if we cut a top of her head off, this is if we cut her face off, and this is if we cut her down the side. And you can see that it's got a bit bigger. And also you can see that there's a line across it. And what this says is this is bled. And when you have a bleed, the blood products divide out. So you get the watery stuff higher up and the thicker stuff lower down. And so that's what it looks like. And although that looks fully white and this looks like it's a line in a different direction, you've got to remember that these scans are done with her lying on her back so that the lighter stuff is dark and the brighter stuff is heavier. So it lies down. And so lying down on her back, that's where it was. I'm going to move this out of the way. It's getting in my way. Oh, sorry. So it's there and here and here. So it's bleeding a little bit. Again, we couldn't really see what was underlying this at all. It just looks like a little cyst that's bled into it. It doesn't tell us what it is. And that means there's a whole pile of different possibilities as to what this could be. So there we go, some arrows. Now, a couple of months later, she was admitted to the next door hospital where there's an A&E department, becoming a bit weaker down the right side. And I think you can see quite clearly on this scan that everything's got a whole lot bigger. And when you've got blood on an MR, it's actually quite difficult to interpret because different densities, different ages of blood look different on an MR. So we'd got a lot bigger and it all looks a bit different. We're not sure if there's something in that, nothing in that. There wasn't anything that enhanced. So when we gave an injection of contrast, it didn't light up and tell us what was going on, but there was obviously something going on. We did an angiogram to make sure there wasn't an underlying blister on the blood vessel, an aneurysm, or an arteriovenous malformation, which is an abnormal collection of blood vessels, and there wasn't anything. We just had this. And so we had to work out where to go from there. And really, not only to treat her, but to try and get a diagnosis. And this was one of the issues that we came up against. So this is a picture of your brain. And in your brain, there are certain areas that are really important that do things like movement or speech or vision. And if we look here on this picture, the red thing is the primary motor cortex. And what happens is if you damage the primary motor cortex, that doesn't recover very well. And you can see how it goes to the midline. And so her primary motor cortex was somewhere here, maybe just into it, maybe on the edge of it. Couldn't quite be sure from this scan. And certainly I thought initially that this could well be in the primary motor cortex. And operating that, you can cause damage and you can cause a permanent weakness. So what you can do is you can use something called neurophysiology, where with somebody asleep, you get the neurophysiologist, they put little recordings in the muscles of various bits of somebody's body while they're asleep. And then I can stimulate the brain with a little tiny stimulator, pass a very small electric current through it, and it will stimulate the brain to work, and the impulses will go and that little muscle will contract, and they can see that on the screen. So they can tell me if I'm in the primary motor cortex. Am I there? What they can also do is, depending how strong a current I use, will give me an idea how close I am. So if I use a current of, for example, 2 milliamps and I get nothing, that's good. But if I use a current of, say, 10 milliamps and I start to get something, that means I'm about 10 millimeters away from either the primary motor cortex or the tracks that lead from that to go down to the other part of the body. So when we were thinking about how to operate with Toni, we felt it would be better to use this neurophysiology whilst we were doing the procedure. We had TV cameras, and this was channel 5. And I just thought it'd be interesting. So there's good things and bad things about TV cameras. The bad things are it makes the whole thing much more stressful. both for Toni, but also for the medical side, because you can look like a fool if something goes wrong. It, you don't really want that to be shown on the TV, but there's good things about it as well. And I suppose for me, it's good to highlight the problem that, people have these things and actually they can do well. And also to tell people about what we do in Liverpool. So, in the UK, for those people from abroad, everyone thinks everything happens in London. And there's some really good people in London, but there's also some really good people in other parts of the country as well. So it's nice that, you can see practice done elsewhere. Toni gets a permanent record, and not many people get to see what their brain looks like, certainly not on telly. And I guess from another point of view is that if I'm treating somebody in some way, I should be able to justify that. And I should be able to explain that, not just to Toni, but not just to my colleagues, but to everybody. And if I'm doing something that I can't explain, maybe I'm doing something wrong there. And so I've always been of the opinion that having the TV cameras in is more stressful, but it acts as another sort of check in the system to show that what you're doing is, I think, the right thing. Right. So the next thing, I've got some clips. This first clip is the sort of start of the surgery, the positioning and the other things. The only bit of surgery in this is we drill a hole. Now, you may or may not like that. You'll see that. And you'll see a little bit of the brain. So I'll start that going. So this is the second video. There's again similar sort of intraoperative pictures, but this is more about the neurophysiology that I mentioned, the mapping of what's going on, and Mike, the neurophysiologist, about what he's doing. So let's play this one. As I said, they're all just
40-year-old Toni.
And then this is the last section, and there is a bit of the operation in this, a bit of cutting in through the brain and taking this blood clot and other stuff. There you go. So these are some post-op scans. So Toni did very well, as you can see. She woke up. Her weakness was dramatically better very, very quickly. The scan on the left I put on because this is from the CT scan, and this shows a side view, and it just shows how we got in. So you can see there's the hole in her head. And when we close it, we put little plates and screws and a little cover to cover the hole and just to hold the bone back in place. And then these are the scans that we did afterwards, and we can see that that big thing is gone, very small, but we were close to motor cortex, and Mike was very helpful in that regard. So Toni's done really well, and you'll hear from her in a bit how that happens. And I guess in most people, this would be where it ends, and this would be where, once we had a post-op scan that looked good, I was clear that everything seemed to have gone, then I was discharged, and normally I wouldn't necessarily see people again unless there was a problem. But with Toni, things were a little bit different. So Toni, I got a message through that Toni wanted to know if we wanted to do a parachute jump to raise some money. And we looked at, and I said, yeah, okay, I'd never done one, but I had no reason not to, really. And we looked to see who else might want to do it. And so we had a group of 4 of us. So there's Toni here, and then Laura was one of the film crew, one of the producers of the other thing. And we had one of our nurse specialists as well. So there were 4 of us who did it. We went up and we raised, thankfully, some money for the Cavernoma Alliance and for the Walton Centre. And if you're interested, I've got a little video of it. This is very short and reduced to here. They got me to put my hand up to see if it was still steady. Look at that. So yeah, that was really an experience. Thank you, Tony, for making us do that. That was good. And then we did one last thing. Uh, so at the Walton Centre, we have a Tough Mudder team every year. Tough Mudder is an obstacle course, a sort of muddy obstacle course. It's basically a playground for adults, and there's lots of mud. And Tony came with us on a specialist, and yeah, that was the team. So that was really good. It's not, I confess, it's not something I've done before with people I've operated on, but I think all due regards to Tony for one, making us do the parachute jump, and two, making it around the Tough Mudder course and actually enjoying it. So I'm going to stop there because I'm all done, and I'm going to stop sharing and pass you back to Helen.
Fantastic, lovely. I'm just starting our videos and I'm muting us all. There we go. Professor Brodbelt, thank you so much. First of all, wow, how brave. I think everybody was looking at you thinking, oh my God. I mean, what you and Tony did jumping out of the plane is incredible. And also, I think I was just really struck by the skill needed to undertake that surgery. It's extraordinary, and our community is very lucky that we have an incredible team of neurosurgeons in the UK and are able to access that through the NHS. So thank you ever so much. And I think, other things struck me. One is it's really important to celebrate the hospitals we have around the country. Things can be very London centric, and as you say, the Walton Centre has an incredible reputation for the surgery that it undertakes for patients with neurological conditions. And I think that's really important that we acknowledge that. And I think the other thing was, I know many of our patients, when they're first diagnosed, there's a concern about cancer. And what you've illustrated there are the challenges about why it can be so hard to actually ascertain what it is and the skill required in doing that. So thank you so much. So we're now going to move on to Toni. And just before we do, I just wanted to share we've got 23 people on tonight's webinar. I know if you're a participant, you won't be able to see the numbers. So it's wonderful to have so many people up and down the country and from overseas as well. Thank you ever so much. And just a reminder, if you have a question, when Toni finishes, we will be coming to questions. That could be a question for Toni or a question for Professor Brodbelt. Please do put that in the Q&A, and then we can ensure that your question is asked. So, Andrew, I'm just going to pop you on mute and stop your video just for a second there. So, Toni, we're going to move to you now, and I'm just going to put a spotlight on you for a second. So, thank you so much. I think it's amazing that you agreed to have the film crew follow you. That's not an easy thing to have done, but I know it means an awful lot to the Cavernoma community, because by doing that, you've helped raise awareness, and you're doing that again by coming here today to talk to our members. So thank you so much.
Well, thank you for having me, Helen.
Oh, it's our absolute pleasure. So I'm going to put a couple of questions to you so people can hear a little bit more about your experience from a patient perspective. So the first one is, if you could tell us a little bit about how did you feel in the run up to that surgery? We've probably got people on today's webinar who are thinking about surgery or perhaps have got surgery planned. How are you feeling, and what helped you to prepare for what was a big operation?
To be honest, I was all over the place. It was a really scary situation to be in. I think I just tried to keep a brave face on, I suppose, for my family and my loved ones. At one point, a couple of hours before the surgery, I was thinking to myself, what if I go down and I don't wake up? These are the things that were going through my head. But I think what pushed me through that, I knew I was in good hands with Professor Brodbelt and his team at the Walton Centre. I decided to have the surgery, so this was it. Then I went down to theatre, and the rest is how it is today.
And I think, Toni, it's lovely that you had that confidence in your surgeon. And I know for our members, finding a surgeon who you can have those conversations with, ask all the questions you need to, is incredibly important. And just for anybody on today's webinar who's preparing for surgery, on our website, we have a list of questions that you might want to ask your neurosurgeon before you go into surgery, so you can have that confidence that Toni did as you were ready.
Yeah.
So thank you ever so much for sharing that. So the next question is, we're going to have people, as I said today, joining us who are waiting on surgery or thinking about surgery. And something people often ask us is, what's it like when you first wake up? What's that first day like? How does it feel in the first few weeks? How long does it take to recover? I'm conscious everybody's different, but would you mind saying a bit about your experience of how it was after surgery?
Not at all. So I remember waking up straight after theatre. There was a nurse. He was singing a song. And it brought me round. And then I remember the following morning waking up. Professor Brodbelt coming into the room, checking in that I was okay. So I spent 3 days on the in the Walton Centre where he had me surgery. I was on ward dot. They were amazing. They looked after me. They really did. Things were a bit confusing, but the main thing was I was alive and well. And then the reality of it, a couple of weeks later, that set in. But I just had to keep a strong head and build myself back up. There was no other way. I was either going to go down being depressed, or I had to stay strong and rebuild everything again.
Toni, thank you for raising that about how we experience that emotionally and that mental health side, because I think often through surgery, the focus can be on having the surgery, is the surgery successful? But we know from our experience, for a lot of people, there can be that elation, and then afterwards, actually a lot of processing. And I think something just to say to people on today's webinar, if you're feeling a bit low in the run up to surgery or after surgery, we do have a counsellor. She doesn't have a waiting list. Her name's Robin. And if you're a member, you're entitled up to 4 free sessions of counselling. So get in touch with our helpline. If you go on our website, you can find the email address for the helpline. And we'd love to support you in that way. So, Toni, if there's somebody here, waiting on that surgery, what would your advice be to them? What would be your kind of top tips for somebody?
Just trust in your surgeon and the team. You're in good hands. And be brave. That's the only advice really that I could give. That's it really.
I think sometimes the simplest advice is the best. And lastly, before we open up to questions, how are things for you today? Because I know people often wonder, how is it for people, when they've had time to fully recover?
Yeah, life's good and I'm healthy. I do have some brain fog. I suffer with short-term memory loss, but it's getting better. And if I do get a little bit overexcited and I'm trying to get everything out at once, I have a little bit of slurred speech. But I'm just grateful to be alive. And I can't thank Professor Brodbelt and his team at the Walton Centre enough. Because without those people, I wouldn't be here today.
Toni, thank you so much. And I think you're clearly doing well to have jumped out of an aeroplane. I think that's an absolute inspiration to us all. And I just want to say a big thank you as well to you and Professor Brodbelt for the money that you raised. That was incredibly kind of you to do that for Cavernoma Alliance UK. I know you also did that for the Walton Centre as well. So thank you so much for supporting us in that way. So we've now come to the point in the webinar where it's your chance to ask questions. I've already got quite a few actually. 4 questions. Just to say there's some lovely comments there. Someone's saying amazing, Toni. People really appreciate you talking today. So the first question I'm going to ask is to Professor Brodbelt. So Professor Brodbelt, someone's written to us. They've got spinal cavernoma at T9. So for those who don't know, if people talk about spinal cavernomas and give letters and numbers, that indicates where it is in the spine. And their question is, if you've got a spinal cavernoma, is it better to operate immediately where there's been bleeding and neurological symptoms? Or is it better to wait 2 to 3 months after the acute bleed to operate?
Yeah, a good one. I suppose there's pros and cons each way. Some people think that if you wait so what happens is when you have an initial bleed, the blood is quite solid. You get a blood clot, and that can be quite sticky to surrounding structures. I mean, that's the purpose of a blood clot, really. And so the idea is if you don't need to operate immediately, if you wait a little bit of time, then it becomes much more liquidy, and then you just have the cavernoma sort of sitting there in a little bit of a pool of liquid. And the idea is it makes the operation that little bit safer, that little bit easier to do. You have to counter that with the fact that if you then had another bleed in the meantime, then you're sort of back to square one, as it were. And if you had another bleed, then even though it's not very likely, cavernomas, yes, they bleed, but they don't tend to bleed quite as quickly as Toni's bled. A couple, sometimes they do, but generally they bleed a little bit over time. So waiting, absolutely not unreasonable. It's what many people would do to try and make it as safe as possible.
Thank you so much, Professor Brodbelt. And just to add, whilst there can't be any advice given for an individual, it's really important to act on the advice of your clinician. And we really appreciate you talking, Professor Brodbelt, in general terms, although we do know there's so much variance in terms of where cavernomas are, how they present. So my next question, Toni, is for you, and that comes from Natalie. And she says, how did your surgery change your life for the better?
Simplest way I can answer that question is it's changed my life in every way. The person I was before isn't the person I am today. Yeah, my life's much better beforehand. Before the surgery, much better now than before the surgery. Sorry. Yeah, in many ways, there's a list, so I couldn't say all now, but yeah, it's changed. It's changed for the better.
Toni, that's so lovely to hear. And Professor Brodbelt, that must be so nice to have your patient there saying that, to see the impact you've had. So my next question is for Professor Brodbelt. This is about a child who's 6 years old, and they've got a single brain cavernoma, no symptoms. Surgery's been recommended, and their question is it better to have surgery or to monitor and take a wait and see approach? So there's no symptoms, but there is a concern about a risk of bleeding again.
A difficult one. It depends very much where it is, what size it is, what structures it's in, what it's near. The things that go through my mind. I don't treat children. I only treat adults. But the things that go through your mind are, what are the risks if you have another bleed? So if you have another bleed, which once you've had one bleed, it may well have further bleeds. And if it's in the brainstem or somewhere sensitive, then if the bleed causes damage, you may not get that damage back. So there's a lot of things that go into making that decision of whether you can leave things and watch or whether you need to do something about it. But as I say, it comes into exactly where it is, what the size of it is, and symptoms if people have them.
Thank you so much. And for those who are on the webinar, some of you may have heard or not heard about a study called the CARE study. So cavernoma is an area where we need more research. We want more information to help neurosurgeons make those decisions. And at the moment, we don't have enough. So Cavernoma Alliance UK has been working with a range of consultants, neurosurgeons, neurologists up and down the country, led by our chair of our medical advisory board, Professor Rustam Al-Shahi-Salman. A pilot study was completed, and we're very keen to see more funding to help answer that question about, is surgery or wait and see better? And if anyone would like to know more about what came out of that pilot study, go to our website, and we've got a web page all about the care study, and there's a lovely animation that explains what they're looking at and what information was found. So thank you. Another question back to you, Professor Brodbelt. So a member has familial cavernoma, and for people who are not aware of what the difference is, about 20% of people with cavernoma have an inherited form. And if you have the inherited form, you're more likely to have multiple cavernomas. Not always, but more likely. So this person has a spinal cavernoma in C3-4. They've also got a brain cavernoma and a new one in the cerebellum. And they've been getting symptoms of pain and numbness. And the question they have, and this is quite a common one for people with multiple cavernomas, is how do you know which cavernoma is causing the symptoms? Is it the cavernoma in the spine? That's actually been partially resected. Or how do you know if it's maybe the cavernoma in the brain?
I guess it comes down to, thank you for the question. I guess it comes down to, going back to our medical training of taking a history and doing a proper examination, and working out where you think it is most likely. Problems in the spine can give slightly different signs, slightly different symptoms than in the brain. Once it's high in the spine, it can be a little bit more difficult. So you can get an idea. Not always right, but you can try and work out where you think the problem might be coming from symptoms people get and the examination findings. The scans help a bit, and certainly if you've got something that's bigger and growing bigger and people are getting worsening symptoms, then it sort of points towards that.
Thank you. So the importance of a clinician taking a really good case history and being really curious and having a look at those scans, seeing if they're giving any indications as well. Thank you. So I've just got one more question again for you, Professor Brodbelt. Sorry, firing them at you today. Just to say, if anyone has any further questions, please do pop them in the chat in the Q&A. Otherwise, after this last question, I'll wrap up. So this question comes from Judith, and she says, do you classify what you removed as a bled cavernoma? I had 6 cavernoma and 1 removed a few years ago. I still have many issues, especially epilepsy. How often do you have people who have multiple operations, as this may be a possibility?
Yeah, good question. So, yeah, people with cavernomas can have multiple cavernomas, and it depends what's causing the problem. So, can you have multiple operations? Yes. Obviously, each operation has some risk associated with it. So, when you have multiple cavernomas, you don't automatically operate on every one. You're only going to operate on the ones that you think are symptomatic and that you can safely deal with. And it can be quite challenging. So can you have more than one operation? Absolutely. Can you have many operations? Yes, but each time there's that little bit of risk, just means that everything is, and that adds up over time. So, neurosurgical technique is getting better. The surgeons are getting better. And, there's some exciting new things coming out that don't involve drilling holes in your head. And so, I think that certainly with cavernomas, there's a lot of interest in other ways of treating them. And as Helen said, the CARE trial, looking at stereotactic radiosurgery, looking at LIT. I know you've got a webinar coming up about LIT in the future, and other ways of treating them. There's a lot of interest in that, and that's quite exciting.
Absolutely, and thank you. That's a perfect segue to say in January we're going to be publishing more of our webinars, and I'm really pleased to say we're going to have one on stereotactic radiosurgery. Some of you may be familiar with that, some not, and that's an alternative to neurosurgery that can work for some people, particularly where it's in a hard to reach area. And also really excitingly, there's a new treatment available called LIT. So that is for epilepsy caused by Cavernoma, where it's resistant to medications. So we're going to have a whole webinar on Cavernoma-related epilepsy and about LIT from a clinician who's right at the heart of that. And Toni, just to let you know, someone's reflecting back on that point you raised about how valuable it is to have trust in your clinician. So we've had someone join, Hannah, to say, I had a Cavernoma removed from the top of my brainstem in July this year. The operation was performed by Professor Tydrick Bolters in Southampton. So he's our new neurosurgical lead at Cavernoma Alliance UK. I had complete trust in him and in his team, which really helped get through the ordeal. I'm still struggling with numbness and pain, but I'm gradually improving. So I think that's really resonating, what you said there, Toni, about trust in the clinician. And we've just had 2 more questions come in, actually. So I'm just going to pose those. Professor Brodbelt, back to you again. I think it's lots of questions for you. And the question is, if a Cavernoma causes symptoms, is it best to remove it or try medication initially to manage those symptoms? And does your age affect the success and recovery after surgery?
So a lot of it depends. You can't give one answer to that. It's a good question because it's what you're often faced with. And I guess the thing is, you've got to balance. Let me take a step back. I suppose the way I think about it is, these are not tumors. These are not cancer. These are not things that, if you leave them alone, mean that people have a limited life expectancy. People can have a normal life with a Cavernoma. And you can have drug treatment of your Cavernoma-induced symptoms, most commonly epilepsy, and that can help sort everything out. And you may never have any other problems from it. So to justify surgery, you've got to have a reason for it. And sometimes, as Helen said, it's poorly controlled epilepsy that can be a challenge. And so taking the lesion out can sometimes help that, although not always. And it comes as well down to where it is, how risky it is to get it, what size it is, are there multiple ones, what you or what the patient wants, what can they live with them, and age does come into it. If you're younger, it can be higher risk. If you're older, it can be higher risk. And certainly, the wrong side of 70, it means the risk is going to be higher. And you wonder, do those risks outweigh the benefits? So yes, there's a lot of things that come into it when you're trying to work out who would benefit from surgery. And most surgeons should chat to you about that and talk about the different options and sort of come to a sort of informed decision with you about what might be best.
Thank you so much. And so just got one more question just before I come to that. Toni had comment to the panel saying, wonderful webinar, and to have 2 sides of the Cavernoma surgery story is very, very rare. Thank you. And just a question to you, Toni, and that's, did you speak to anyone that had already had surgery for a Cavernoma before you made your decision to have it operated on? And then just a point there about CAUK for anybody here who's going through these sort of decisions about should I have an operation or not, to say that CAUK has a buddying scheme, and we can buddy you with somebody who's walked in your shoes. So yeah, Toni, did you chat with anybody about it before?
No, I didn't actually. I'd never heard of Cavernoma cysts before. It was all new to me. And as I said before, we came on live. It was a pretty scary time. I felt quite alone. Because I didn't want to worry my family and my loved ones, even my friends. Because I was scared each night I'd go to sleep and I'd be worried that I wouldn't wake up the next morning. So if I'd have been involved with Cavernoma Alliance, then it would have been great to have a buddy, someone that I could talk to. So I think Cavernoma Alliance is a good outlet for people who are living with cavernomas.
Toni, I think your experience is so common. We hear on the helpline A lot of people say they don't want to worry loved ones. They don't want to put that on them. So they shoulder that themselves, and that's not easy. If anybody is on the webinar today and you're keeping this to yourself and you've not shared it, do get in touch with our helpline. You can email us or you can book in a telephone call. We're not clinicians, we don't have all the answers, but we want you to know you're not alone and we can share our lived experience. And Professor Brodbelt, you've got your hand up there.
Yeah, just wanted to make one comment because I think the other thing with Toni is we didn't know it was a cavernoma. We didn't know it was a cavernoma until we're taking it out. And so it's almost even worse for Toni in the run up because she didn't. I wasn't really telling her. She had this thing. We didn't know what it was. There was a whole range of different possibilities, and the Cavernoma Alliance is great, but we didn't know it was that. It could have been a tumor, and that's a whole different set of charities and support processes. So, I think part of the issue is sometimes at least we then got a diagnosis, and that was very reassuring on one side. But it meant that Toni was sort of even more in the dark in the lead up to things.
Yeah.
It's such a good point. As you say, we know it's hard to diagnose rare conditions, and as the scan showed, it wasn't clear. And people then living with that uncertainty, it's not easy. So it's a really good point to add. So I'm going to ask one more question. It's going to go to you, Professor Brodbelt, and then we're going to finish for tonight. It's been fabulous to have, so much engagement from people and wonderful to have the opportunity to put these questions to you both. And so that last question is about medications, and someone's saying, do medications such as steroids have a place for treatment?
So thank you for the question. I guess what I'd say is not in the way that they're not a treatment for cavernoma. They're not something that you would want to be on long term. There's all sorts of side effects to steroids, but as an adjunct to surgery, absolutely. So by doing an operation, Toni will have gone on steroids for a short period afterwards that just reduce the swelling and reduce the symptoms afterwards. And it just makes neurosurgery safer. Before the onset of steroids, neurosurgery was a much higher risk condition. And steroids make us able to do much more in the way of operating and do things that we couldn't do if we didn't have that facility. But it's not a treatment in itself for cavernomas.
Just on that, as a charity, we're advocating for drug development to find medications to treat cavernoma. At the moment, the options are wait and see, or neurosurgery, or stereotactic radiosurgery. But what's really exciting is here in the UK, we are co-funding research into a gene therapy treatment. That's happening at UCL. And overseas, there are trials looking at drug repurposing. So looking at drugs like aspirin, propranolol, or torvastatin, exploring could that help? And also we've got pharmaceutical companies looking at new drugs. So there's lots of interesting research taking place, and we're really hopeful it's not going to be anytime very soon, but in the near future, we would love to see, and we're hopeful that we will have some options that don't just involve surgery. So before I finish, I just want to say some lovely feedback in the chat. Toni, to you from Yolanda, she says, thank you for the presentation. Amazing to see the videos. And thank you for answering our questions. Toni, you're an example of courage. Absolutely agree with that. Someone else saying, thank you all three. Great presentation. Very helpful for me. I'm newly diagnosed with symptomatic brainstem cavernoma. And someone else saying, great. That's great. Thanks, everyone. So Toni, Professor Brodbelt, it's clearly been a very valuable webinar. People on the chat have really appreciated it. It's so kind of you to give up your evening to spend time with us today. Wishing you all a really good evening. Goodbye, Toni. Goodbye, Professor Brodbelt.
So much. Bye.
And good night to everybody who's joined us on tonight's webinar. Hope you have a safe evening. Bye-bye.